Okay, well, welcome everyone to our monthly ABIN virtual webinar. We're so glad you are here with us this morning. Today we have an amazing speaker. Her name is Dr. Manson, and I'm just going to spend a moment reading a short bio, telling you a little bit about Dr. Manson before she gets started. Lesley Manson has spent nearly 2 decades providing direct service. Her dedication to behavioral health and integrated care models led her to directing behavioral health programs, providing continuing education to healthcare professionals, and developing workshops and trainings for behavioral health and primary care providers to be successful and integral members of healthcare teams. Her history as a healthcare executive has led her to voluminous national presentations on integration with both clinical and management focus, and providing consultation and training for primary care and medical behavioral healthcare organizations, and developing and auditing for integrated behavioral health quality and fiscal sustainability. She develops Train the Trainer and additional educational programming for numerous contracted agencies, such as Centers for Medicare and Medicaid, CMS, National Center for Interprofessional Practice and Education, and various federal and independent medical associations and organizations. She is a master trainer for the Institute for Healthcare Communication and conducts workshops in the area of motivational interviewing, clinical patient interaction, team-based care, empathy, and communication to meet healthcare's triple, quadruple aims. She is a principal at Team-Based Education and Management Solutions and serves as a clinical associate professor, program director, and associate chair of integrated initiatives at Arizona State University Doctor of Behavioral Health program. We've had the opportunity to interact with Dr. Manson over the past several months, and she has provided us with a wealth of knowledge. We are so excited that she is here today presenting to our Arkansas audience. And with that, I will turn it over to you, Dr. Manson. I will ask that everyone mutes their microphones. If you have a question, we will have time for questions and answers at the end.
Thank you, Kim. Hi, everybody. I hope everybody can hear me fine. That was a wonderful welcome. And we're going to just kind of jump on in, but I do want you all to take a moment and consider your questions related to financing and building integrated care, because today and next month, we're basically going to go over different aspects of financial management for integrated care. Everything from billing and coding pieces to pieces about developing pro formas or other types of financial management tools, to return on investment and how to actually display that, to picking and choosing best metrics to demonstrate your value, both financially and related to performance and value-based purchasing. So we're going to go over a lot of topics, but all very briefly, since we only have an hour each time together. So please kind of start to consider what those questions are, and I'm more than happy to answer them for you. And if I cannot answer them, I'll come back with resources or other contacts who can certainly answer them for you. So let's go ahead and jump on in. I do want to note, if anybody would like, you're more than welcome to type any questions ongoing, especially if something comes up in the moment in the chat box, and I'll be looking at that and trying to be as responsive as I can to that as well. Okay. So let's jump on in. Really, everything today and next time is going to be focused on building sustainability in integrated care. So one of the first things I always just kind of want to briefly go over is the fact that there is broad support for integrated care across interprofessional guilds, national and international government administrations. In addition, integrated care is wrapped up in legislation, payment reform, and most grant opportunities now. Okay. And when we start to consider where we've been and how far we've come, over the last 10 years, we've seen significant growth of identified and supported integrated care sites across the US. So if you're looking at your screen on the left side, we've got about 10 years ago where integrated care sites were just starting to develop. And now on the right side, you've got about last year's link to what is integrated care sites. And look at how much they've grown. Okay. What we realize now that if you're not participating in or you're not starting to build your integrated healthcare delivery system to really be fully sustainable and demonstrate that value, then you might be starting to fall behind in innovation of healthcare and really where the future of prospective funding is going. Okay. As we recognize too, the United States in specific has built in integrated care into large-scale legislation such as the ACA and ongoing smaller legislations that continue to pass every year. So last year, further legislation passed. This year, there's already proposals. There's 3 proposals already going through the legislation related to integrated care efforts and continual funding of them. And I'll talk a little bit about those later when we look at some of the billing codes. Well, one aspect is the National Quality Strategy, which is what we are all required to be looking at and making sure that we're developing. And if you look at it, basically, it's the quadruple aims of healthcare. That's what the National Quality Strategy really is. And in specific, they do call out integrated team-based care. And overall, in the legislation, what we've seen is they've had little ties and comments to both the primary care behavioral health model in specific and the COCM model in specific. So just so that you know that as well. Now, we all know the reasons why we're building integrated care services, and I'm sure all of you on here or many of you already have integrated care sites or know the value there, but just to kind of reinforce that, right? We want to start thinking about that and kind of going back to why did we want to do this? Not just because we received a grant, but what are the other reasons why we want to do that? Because those reasons are also things we're going to tie through into what we're going to look at for value-based purchasing and our metrics for demonstrating, okay? So perhaps it's because you understand the significant link of mental health and the impacts of social determinants of health and daily behavioral lifestyle choices on overall physical health or premature death. Perhaps maybe you considered implementing integrated care because you wanted to provide additional support and lessen the burden of primary care providers. Because unfortunately, if you look at the stat down below of the risk of suicide for our primary care providers and physicians, last year, okay, the suspect is that it went up almost to 600 to 700, okay, deaths. And that's really significant, okay? This is going way above what the average of suicide risk is, okay? It's also important to recognize that you might be implementing integrated care for all the reasons. You want to improve the health of your communities, your population, but also help reduce all of the burden that your healthcare staff and your providers go through every day and really demonstrate this as a team-based value. In which case, we want to go ahead and demonstrate our integrated care through full metrics related to these aspects, okay? But when we start to consider integrated care, it's really needs to be emphasized that we consider it as a standard of care. Oftentimes when we jump into receiving money and financials to support it, what we do is we bring on an additional team member, right? Or we build a program, right? Or that room down the hall, okay? And it's really important to take a step back and consider this as, am I just supporting a program or a person? Okay, or am I really starting to look at how our healthcare site is saying integration or integrated team-based care? It's a standard of how we deliver healthcare, how we deliver our primary care services, how we deliver our X services. It's really essential we consider that, because once we've made that decision, it'll be easier to start to embed the other pieces related to financial structure and value-based care and our metrics that we need to. We really need to pull it all the way through. In addition, what we want to ask ourselves is, how are we integrating care? What does that look like? How are we doing it? And oftentimes we're just kind of operationalizing, we jump, we build the plane while flying it, but we really need to look at those aspects of how. One area is to consider, what's the model of integrated care we're using? Okay? We need to take the time and choose the model that best fits our organization, our team, and our community. Each model, as you see here, has specific outcomes which lead to improved healthcare outcomes for our communities, increased financial support in specific, and we must implement these leveraging both model fidelity and data-driven metrics, but also best practice and evidence-supported workflows and interventions. When we do that, we're able to get those outcomes that are reported every single year on integrated care sites. So just kind of like, if there's a shout out, if folks can put in the chat box, I'd love to see what is the specific model you're implementing now. The full integrated care model is what's called PCBH, or primary care behavioral health. And that means you have a clinician that's embedded into everyday services. working alongside medical professionals, and they see individuals at any aspect of time. Okay. You have co-located care, which means that you have a model where the individual might be co-located somewhere. It could even be downstairs or in a separate building sometimes, but on the same campus. And it's someone that you call in or will work with you on an ongoing basis. But oftentimes their documentation is separate from the general medical chart. Collaborative or coordinated care, those are your COCM, which is a psychiatric model, the CCMs or the TCMs. All of those are supported and have specific rules and regulations related to them, and they onboard a specific type of care manager or psychiatric consultant, or all of those. Okay. You also have telehealth types options and bidirectional reverse care, where you're bringing in medical professionals into your predominantly substance use or other types of strict mental health agencies, trying to build an integrated care through that direction. So as we know, each of those different models actually have specific fidelity metrics, specific things that we want to look at related to how we're developing it and how we define our services. And all of them have strict outcomes that are associated with it when you develop the model correctly. Okay. We also know that there's got to be some variability based on the healthcare centers. Okay, and what type of healthcare centers you have and how you're using it. Looks like we've already got some folks saying that they use the PCBH model, which is right now, statistically, the most common model that's being developed across the United States. It's also being developed a lot with other models with it, like COCM or CCM often, okay? So when we look at this, we know that they've demonstrated different outcomes with patient and family engagement, the overall health of our patients and families, and have demonstrated outcomes with our healthcare teams. So let's take a look here. Integrated behavioral health has shown quality outcomes related to specific medical conditions, as you see. And this is all providing average of brief, that's 15 to 30-minute interventions, which have shown promising and lasting results over years. Most of these actual interventions and outcomes have demonstrated success after 4 years after the last visit. So it's really important to recognize that. In addition, there's lots of studies that are demonstrating their success with patients and communities related to the serious and persistent mentally ill populations. Okay. Integrated care outcomes have also demonstrated significant, and I can't strain that enough, improvements in our fiscal sustainability as healthcare entities overall. Okay, recent ACOs reported billions of dollars saved, okay, and with millions and billions of dollars earned related to integrated care. So it's really important to start to look at that as well. So when it comes to the value saved, we're really looking at our value-based purchasing and bringing in income related to that. And the direct money is still there as well. And we're going to talk about that a little bit here. Okay. So if we want to replicate these outcomes, we need to ensure that we have the core elements. So that's systematic and operationalized planning. Okay, that's employing evidence-based brief interventions. That's promoting our change to reflect integrated care across our healthcare system, whether it being in patient communication or engagement or policies and procedures, also related to metrics and data. Okay. Building and refining fiscal structures and return on investment analyses. We need to implement those too. And next month, I'll be going over examples related to ROI and showing you how to demonstrate that and what other integrated care sites have done to demonstrate that. And yes, I have all the references for you, so no worries. What I'll do is there's a lot. On that slide, there is about 20 references. So what I'll do is I'll put it into one page so that it can be sent out separately for ease. Okay. Just so folks know, I'm responding to the chat box so that you know. The other piece is that as we're looking at implementing these, and if we really want to demonstrate those outcomes, yes, we need those pieces. And we also need to ensure that our teams are reinforced on the clinical and management best practice of integrated care competencies. So there's some elements there that are really important to recognize and build into our system as well. And just so folks know too, this is something that you can replicate. And sites have been doing this for over 20 years. And so it's important that we learn from those sites and we take their systems and put it in. We don't need to reinvent the wheel. There are plenty of systems that are willing to give away their smart phrases, their documentation templates, their workflows, everything. So you can view it and then make the adjustments that are needed for your facility. Okay? But with all of that being said, okay, we do need to ensure survival And realistically, we need to do that financially, right? If we really want to serve our communities the best and ensure that our providers are the most satisfied, we need to keep the doors open and ensure our books are balanced. So one of the most common challenges and frustrations people talk about integrated care is related to billing. Okay. I'm sure many people probably already experienced that now. Okay. And now's the time, if you have billing questions or experiences you wish to share, go ahead and start putting them in the chat box, so we make sure that we have time to chat about them. I did make sure I built in time today to answer any questions you might have. So let's take a moment and look at the top most common billing codes in integrated care. To this day, still, psychotherapy codes are the most commonly utilized and billed codes in integrated care. So just so folks know, that is the typical code that most mental health providers are utilizing every day, whether it be an independent practice or in a general mental health agency or in any type of, again, primary care or integrated care agency. Okay, so they are the psychotherapy codes, 90832, 34, and go on from there. So that's important to know that that is the most common code that you can continue to utilize. After that, you've got your collaborative care codes, which you've got your CCMs, okay, your TCMs, or your collaborative care, your COCM, which is the psychiatric model. Those codes are actually building in frequency across the US due to a number of factors. One is that they've been built into legislation, as I mentioned before, and two, there's tons of grants and funding that have been pushed out over the past few years to support it, okay? Hundreds of millions of dollars. And in addition, there's legislation that's going up for proposal, okay, this year in 2022 to expand that money and to write it into legislation that healthcare clinics can actually be eligible for more of hundreds of millions of dollars again, over 2022 to 2025. That's currently written in. Now legislation proposals change, right? Still got a couple more months to make those changes. And right now it's saying that they want to emphasize the COCM model in specific with the PCBH model. So just to know, those things may be coming. The next kind of adjustment on that legislation that's been proposed is that it might be the COCM model or the PCBH, or an or the PCBH. But right now that has not been accepted. So the legislation currently stands with COCM and COCM with PCBH, kind of a piece. So they have to be done either independent COCM or with the PCBH model, okay, to be eligible for that additional funding. Okay. Now, when it writes into legislation, not only is it granting you some additional grants, but it's also being tied to value-based metrics related to Medicare. Okay, so these things are moving and they're not going to go away. They're only going to be continually tied to value-based purchasing, your Medicare payments and reform, and what's going to be ongoing and going to be pushing through the Medicaid system as well, as far as their transformation toward value-based purchasing even further. Okay. With your COCM and your CCM and TCM codes, those collaborative care codes, there's some concerns there and limitations. A lot of that is that they rely on mostly 2 to 3 providers. So you've got, for the CCM and TCM, a care manager and the primary care provider. And when you add on the COCM, or the psychiatric care model, you're also adding on, with the primary care, the care manager, a psychiatric consultant. So the one amount of dollars has to pay for all 3 of those individuals' time, okay? And that time is done setting up for the entire month, but the psychiatric consultant has to consult on each patient that you bill every month. They have to consult related to them, not once a month, but once a week. So the psychiatric consultant's role is actually very heavy in this picture. So it's really important to recognize that in how you are leveraging. The best way to leverage all of the collaborative care models is to consider your patient populations and your registries. You want a large amount of patients in those registries, and you need to be able to demonstrate that these patients need psychiatric level care and consultation. The primary care physician is not able to manage their psychiatric needs on their own. Okay. And that's on their own every single week. Okay. So there's a lot of different pieces in there. Now, just learning about the differences in all these codes would be one webinar for each of the coding systems, right? But those are some of the nuances there. When we start to look at some of the other codes like HBAI, remember those aren't turned on for every healthcare system in every state. You actually have to ask your states to really push that through. And then you also have to ask for them to ensure that they onboard your mental health clinicians onto the HBAI. HBAI is also limited in the fact that those are for medical diagnoses for mental health clinicians to address. So they can actually put down diabetes, hypertension as their primary diagnosis, and that's what they're helping them with under HBAI codes. Mental health providers or any other providers billing HBAI cannot write down mental health codes for that. Okay, it can only be primary care or medical diagnoses. Okay, HBAI also has some other types of rules. For Medicare, they're only reimbursing psychologists, right? So there's all these little tiny nuances to know how to operationalize those codes. They're a little bit lower of a paying code, statistically speaking, and they usually have more limit sets related to how often you can bill that code. Just like oftentimes your psychotherapy codes will kind of stop you through Medicare, or I'm sorry, through Medicaid often will have a limit of either 12 or 24 for the year sometimes. Okay? H&B is actually lower than that, statistically speaking. We also have some other codes on here that you might see. Some of them are just your transition codes. If you're an FQ, you might be doing other types of codes. You might be using GH, other types of codes like that. We have screening codes and perinatal codes. Actually, there are some that are developed for providing education and screening and integrated team-based care. So there's some unique codes in that division as well. I reference E&M codes because one of the values of bringing on another team member is helping the primary care physician or the medical provider to be able to work more efficiently and effectively. So at times you can build on different types of group services where perhaps you're doing pain groups or other types of MAT services or other services, diabetic groups, where you bring those patients together and they're seen. And then you have the team-based care approach where the behavioral health provider is actually providing a large amount of the education that's needed for that specific appointment. And then the provider, the medical provider, is coming in and just doing a small specific procedure or specific intervention that they need to do and closing up the visit. So you actually can bill a higher E&M code related to that or start to develop group visits. So this is something that's very unique and takes a lot of time to set up. Okay, so usually it's for sites that have been doing integrated care for a number of years, and they're really ready to look at what's the next level to really bridge and build on our teams to solidify them even more, to demonstrate how we're working so intimately together. That would be really leveraging your E&M codes. So ultimately what you're doing is you're not billing for the behavioral health provider, you're purely billing for the medical provider. And that behavioral health provider is helping them to get their visits done more effectively and efficiently and helping those patients move through. Okay, that does take a little bit more training. And again, as I said, there's only a few sites that do that. And what they do is they are sites that have been doing integrated care for a number of years. If you're one of those sites that are interested in that, we can always talk about kind of some of the nuances related to that as well. Okay. So there's a lot to talk about in here, but I wanted to just give you kind of a quick overview so you have a little bit of introduction to these codes and know some of the nuances related to it. Now, with coding, there's a lot of problems with reimbursement errors, okay? And that really comes down to just not knowing some of the coding requirements, the billing requirements of it, or perhaps just not having the correct documentation related, okay? There's a lot of specific documentation that's required. So if you are utilizing behavioral health or mental health licensed clinicians a lot for your behavioral health providers, then they have specific documentation requirements. So there's a lot. And so it's always important to go through. You probably won't ever be caught or denied based off of documentation unless you're audited. But then once you're audited, remember, they can take back sometimes 3 to 5 years worth of income based off of those audits. So it's really important to ensure that all of your clinicians are up on best practices related to documentation, and those are aligned with each code and those requirements. Because your states and each of the payers determine what needs to be on the documentation. And I want to do a special nod because these are the areas here that are most commonly missed in documentation when we look at auditing. So some of that is patient's response to treatment in progress, and that is required. Okay. Any coordination related to, since we're in integrated care, working as a team. Functional status is required again, and it needs to be linked to the goals of that treatment for that patient. And it's really important that those goals are SMART goals. okay, all required. These are the number one things that are missed is we'll look at goals and they're not actually SMART. So not specific or time bound. We can't understand how that patient's going to be able to understand themselves, how to measure their success. Risk. And then the last thing I want to note is open notes and no surprises act discussion. Okay. These are the newest kind of movements that we have been recognizing in the legislation and HIPAA, and we need to start to actually ensure that we're documenting related to that. So we need to ensure that upon the first visit that we document that the person understands that we are sharing all of our documentation, et cetera. And that related to the No Surprises Act, it's really important to document that too. So most states, including Arkansas, already has written in that if you're providing services through Medicaid and they are mental health or behavioral health services, you have to have a discussion related timely, how often the patient's going to be seen for care, what those specific interventions are. So again, already coordinated with the No Surprises Act, but that act goes a little bit further related to finances. Now, for all of you that are in agencies, your providers don't necessarily need to discuss the specific finances, but they do need to identify how long the person needs to be in care for what they're seeing. So they need to say something as simple as, right, I'm recognizing that these are the goals that we're setting for functional improvement or for improvements in your care and your life. I see that we're probably going to be needing to meet for X amount of times over the next X weeks or months, in which case that will be 6 visits, okay, to know how much that's going to cost. If you have any questions or concerns with that, the front desk can manage that for you and give that to you. So you need to refer them back so then the front desk can deliver any types of the information related to the money pieces of the No Surprises discussion. So just make sure that that's documented too. So upon audit, you all feel confident related to that. Okay. So these are all things that are going to keep you financially secure as well. But one of the reasons why it's so complicated for integrated care related to financing is because integrated care billing, okay, is challenging. It's tied into areas related to your healthcare institute site license. Some states actually say, if you're going to do integrated care, you have to fill out this state form. And if you didn't, then we don't actually have to pay you for your integrated care services. It's also linked to site type. So we know that the different types of sites, ACOs, FQHCs, if it's reverse integration, you all have different types of billing requirements and coding requirements that you have to abide by. Then you have your payers. So each of your payers dictate what types of documentation, the frequency of your billing, and of course, the amounts that you're going to be receiving. Provider license type is also important because, as you know, based off of your site type or your payers, you might hire a provider that's ineligible to bill for that payer services. So all of these things are intertwined. Okay? Service delivery and coding is really developing that business case and ensuring that you have all of the documentation requirements linked up. Okay. So if you haven't built all of those smart phrases or documentation requirements and there's an audit, then you're going to lose out there. Each of these areas can be something you can review every year for integrated care to make sure that you're consistent, or develop some type of kind of communication with agencies like this and networks. So you can go in and saying, here's our template that we built last year together as a collaborative. To meet these expectations? Are there any other changes anybody's noticed with different payers or systems that we should be aware of to implement? Doing that really helps so that you can actually leverage these networks together and work together more collaboratively to ensure that you can be financially successful. So one way to do that, sometimes people have questions about, well, how do I get all that information? Everything is listed for you. So just so that you know that you have all of the knowledge related to the coding and billing requirements, everything that I've already gone over, all by reaching out to your providers and your payer centers. So you look at your provider manuals in specific, and you contact your payer systems. Now, I do want to say that the payer systems are often overloaded. And so for me, oftentimes it's being put on hold for hours. Has anybody else experienced that? Okay, so when I call in to set up these types of structures, I'm often on hold for hours at a time. So it's ensuring that if you're an organization that's going to do that, you have someone that can dual task at the same time. So they're doing other things. But that's how you really ensure that you're building a fiscally sound structure to your billing and coding requirements. Okay? But also what we need to do is link to all of our values incentives. We need to understand how the payers and get involved with the payers, okay, to improve their value-based contracting and our pay for performance metrics for integrated care. We can do this by all of you linking together to become a statewide voice in integrated care billing. Okay, you can do that through joining collaborative organizations and networks and really being a voice. Most of the payer systems want to hear from you. They want to be able to develop their value-based payment models and contracts, knowing what your needs are, what your community's needs are, to be responsive to that. And that's really their obligation as well, right? So when we look at value-based purchasing, we're looking in specific about foundational measures and performance measures, okay? So we need to inquire around how integrated care at these payer systems are being aligned with the foundational tenets, okay? So you want to be able to have conversations where you're asking them these so that you're better prepared for any type of integrated care contracts related to value-based purchasing or performance that are going to be coming out, where you might want to be sitting there to drive those communications and build them. Many sites that I've worked with have sat down with states and said, I want to be here and help to develop what the integrated care value-based purchasing contracts look like for the state. Also, insurance companies have worked with healthcare centers and large-scale entities like collaborative networks to develop that. So it's not uncommon. So I encourage you all to consider that as well, okay? People really want to join forces together to develop something that's going to work collaboratively for all the agencies and our communities, because ultimately what we want is our communities to be healthier. So just a review of some of the financial incentives related to other foundational tenets, we're looking at building our pay for performance. That's our payment reform. We can maybe consider looking at bundling contracts. Everything needs to be transparent. So we know where risk management and adjustments need to be, where we might be looking at things like financial return on investment or cost savings in general, okay? And we want to be able to plan for those specifically related to integrated care, okay? And when we're starting to talk about pay for performance, we need to understand how that works in risk. So when we're considering integrated care and how we look at risk, we need to understand that framework. We need to clearly see the benefits and lay out a plan for success. And ultimately, what we want to do is not only understand this knowledge at the administrative and operational levels, but we want to be able to translate that down to the provider levels. So they understand that when they're really leveraging and working with patients on care, or perhaps when we're really pushing our patients and our communities to focus in on specific types of kind of targets for the year. We want to improve the lives of our communities by reducing this or improving that we're talking with the providers, that it's part of really risk adjustments. It's part of looking at how we improve the health of our communities. And this community in specific needs that. And here's the reasons why. Okay? So we want to have those discussions. But just so folks know, is sometimes people get scared about value-based purchasing and contracts, but ultimately this is what the average is really looking like. So the common distribution is still a large scale fee for service, and then some shared savings and population-based payments that are supported through it. Okay? But ultimately, a lot of sites are still working off of fee for service. Some might be looking at maybe payments that you're getting per day, per month related to their patient populations, a standard amount. All those contracts are very different depending on the organization and the state. Right? But all of those also come down to kind of looking at this bundle as well, as far as the metrics are derived from fee for service adjustments based off of also what their population and outcomes have been over the past couple of years. Okay? So these are things to really be transparent about, but also take that next step and say, I want to discuss this related to integrated care. I want to discuss this related to bringing on our mental health, behavioral health providers. These specific providers, if you're in a mental health agency, bring on our medical providers to demonstrate this even more so in its value. So when I'm looking at it through that lens, I want to know how our site is going to be viewed differently. I want to know how our site is going to be able to demonstrate these outcomes more effectively so that we can secure this long-term. These are the questions we need to be forthright in asking with our payers and sitting down together as a community. But remember, if we're really wanting to build sustainability, bottom line is we need to be able to demonstrate that fiscal evidence, okay? And right now that's through our fee for service and the money that we know is coming in. So value-based contracts, if you have some, then we're gonna wanna build those into what I'm gonna talk about next. But if you're not, and you're still in the beginning stages, then you're going to want to just look at the finances you've been being brought in right now with integrated care services and building them. So I want to show you one of the number one tools that people use is a pro forma. Okay. Many of you probably are very familiar with it if you're in administration or operations. Basically, it's a method of calculating your current or projective, fiscal results. It's a Word or Excel file, basically, and it's demonstrating whether or not this person or program or your healthcare site is fiscally sound or if you're costing money, right? So are you in the black or the red, basically, in the end? But it's also very helpful because you can look at it for perspective pieces. You can project in the future and see. So if you're a site that's really wanting to build on integrated care and you're worried about that, you can do the pro forma first to see, is this going to be fiscally sound for me? What's the bottom line that I need to look at related to the access or productivity, or the access to care for my community that I need to make sure that we're meeting? And how do I do that? The pro forma, though, is a very large document. You can start it being very simple, and I'm going to show you a simple one today, but it can also be very complex and helpful in a lot of ways because it really is linked to all of your kind of fiscal sustainability areas. So it's linked to just general fee for service. This is what I'm getting direct pay for. It's also linked to any of your outcome measures, performance measures. It's linked to all of your return on investment and cost savings. You can actually program your pro forma to do all that for you. So in the end, anytime you have an adjustment in finances or an extra team member joins, this Excel document does all of that for you. You change your specific metrics and you've loaded it in, then it'll go ahead and provide you with that outcome of the return on investment for those metrics every time. So the pro forma can be real value once you develop it well. So it's going to be that demonstration of your costs again, and all of the income that you're deriving from the people that you're working in your integrated care program as well. How you develop it is you're going to look at job descriptions and data points, performance indicators you already know and you use now. Maybe it's going to be looking at how you want to build the program in the future. Do you want to operationalize it now for one person, 5 people? You might want to include any type of dashboards you already have. And again, those working metrics. And when we talk about metrics next month, I'm actually going to show you a lot of the standard metrics for integrated care, what healthcare sites are doing across the country right now. But basically, there are elements that are going to help us guide our performance. And traditionally, what we go toward is all of the national metrics. So National Quality Forum, NQF, where you can look at QCDR, the Qualified Clinical Data Registries, HEDIS, right, Healthcare Effectiveness Data and Information Sets, NCQA, of course, which is part of HEDIS, the National Committee of Quality Assurance, UDS, which I'm sure everybody's familiar with too, Uniform Data Service Systems. So we can go on and on, right? Joint Commission, if you're there, if you're one of those, or so there's all these pieces we can look at as far as our metrics. And that's where we want to align, is on those shared metrics that we all need to be reporting anyway. We want to align our integrated care systems to be demonstrating that effectiveness. And I'm going to talk more about that next time. This is a little bit about what a pro forma looks like when you see one. This is a base one. And there's actually tools to help you with your pro forma development. So here's a tool that just is a worksheet that's very easy, as you can see, to do and complete. So the pro forma can be very simple to do. And I can provide some of these kind of tools if people are interested in them. And if you're interested, I'd love to right now take a moment, and I'm going to open up a couple of pro formas to demonstrate what they can do for integrated care and how they can show you your fiscal sustainability. So I'm going to stop sharing for a moment so I can flip screens. So give me a moment. And I'm going to show you 2 pro formas, one that's very simple, and then one that's a little bit more complicated, so you can see the diversity that you can have with these as well. So here is a simple pro forma. On this pro forma, you can see that there's an area for direct revenue, and this is an individual that is actually part-time behavioral health provider at a small medical practice in a very rural area. So they could only obtain a behavioral health provider for part-time. So they're about 20 hours a week. And this is their actual data. So this is what they provided for their data. Here's all their billing codes and top insurances that they take. And then on average, how much they're getting reimbursed for their codes. So you see it spans from 90832 okay, 34, 37, 36, 37, I should say. And then they also have the 90791, which is related to more of your initial assessment, okay, with patients. So they go through the codes and then you have all of them listed and the frequency. And then in the end, what you have is the amount of money that you're obtaining from billing these codes each month. This corresponded to the amount that they were collecting, okay? And then what you're going to look at is the person's salary. Because this person is part-time, their salary is actually just dictated. It's a set amount and they receive it every month. So it was very standard for this person. We did have kind of a sketch out about what the benefits might look like. So how much additional cost there might be. Okay. But otherwise you see in the end, this person is actually in a positive. They're bringing in more money than they cost the healthcare system. Okay. Or this healthcare site, as I should say. So very easy tool to utilize with data that you already have. This is just pulling data that they already had and putting it into play. Okay. I'm going to share now another pro forma that's a little bit more complex so you can see how large that they can be. Okay. Just to give you another example. Okay. This is another pro forma. It's a little bit more larger pro forma of an MAT program. Okay, so you see that there here we have benefits, we have personnel, and you can see their costs, okay, going across, and there's a few different people here. And how much pay is it contributed? You can see there's a couple folks that only 50% of their pay is contributed to this program, okay? So we're marking off that. So benefits and salaries and other expenses, okay? So we have all of that listed here, okay? Then we have here the revenue generation from this MAT program. And look at all the codes that could be utilized for this MAT program. You see how far I'm going down? Okay, these are all the codes that are utilized. Now this center has an AIR rate, an all-inclusive rate, okay? So just so you know, so they're billing a little bit of Medicare, Medicaid, and some private insurance. So in the end, we have all of the costs and possible reimbursement rates for that's on average for them. We average it out and the frequency of these codes being utilized per payer. So in the end, it's all averaged out per payer. And then you have, on this sheet, you have the total costs and expenses, the total revenue. And the revenue is always dropped in these forms. You always want to drop it down to 85%, knowing that there's just going to be a percentage that you don't get reimbursed for whatever reason, right? We know sometimes we don't get reimbursed and we should be, and sometimes we do get reimbursed and we shouldn't be, right? Because of documentation or other errors that haven't been caught. Okay, so we always want to build in a little bit of that leveraging for ourselves. Okay, so again, here, they also are demonstrating an outcome where they have profit, they have sustainability. They're able to keep this center open, okay? And obviously you can see this is a larger scale financing versus the last pro forma. In addition, this pro forma is also built in where it pulls in the data. Okay, this is linked into their operationalized system. So it actually links in the data and shows all of their metrics for their MAT program and exactly how they're actually going to pull their metrics out statistically. So you see here over on this side, these are all your statistical numerators and denominators. So they actually can demonstrate that. And then in the end, we operationalize it to return on investment metrics as well. But I'm going to go through because this is another large scale entity. So they have a lot of metrics. This is uncommon. A lot of places will only have about 5 to 7 metrics usually. Okay, this place is a lot larger. Okay, so it keeps going down as you can see. And they have them actually put into categories based off of grants and standards that they need to meet, okay? But just so you can see them, okay? And they're all linked to this specific MAT program, okay? Organizational outcomes, and they have satisfaction at the end as well. Okay, so as you see, it keeps going. So what a great thing is to be able to have these types of documents, these pro formas that are going to be working for you as well. Okay. So this is something that I would love for you all to consider to develop. And again, if this is something you're interested in, there are great tools and different types of learning mechanisms that you can have to be able to demonstrate this. Okay. So you don't have to do it on your own if you're unfamiliar with it. Okay. So I'd love to hear too in the chat box, if any of you have already developed your pro formas and linked them already, to your metrics. It might be something that's helpful for you to be able to come on and share that with other team members and entities here. Okay. So we're heading toward the end of our time for today, but I wanted to kind of go through a few more things and then take a lot of questions, because I want to be able to ask any questions you might have related to financing. Perhaps there's some codes you've been billing, they're not being reimbursed. Perhaps you're wondering how to bring on or which codes to bill for this program or for this type of person at this type of healthcare entity. Get ready for those questions, and I'm going to be ready to answer them, as many as possible here in a moment. But I want to set you up to recognize that next month, what we're going to do is I'm going to actually show you some of the quality measures and metrics that are common for integrated care across the country right now. And usually what we look at is specific measures and metrics in each of these categories. We look at specific population health or kind of specific clinical quality metrics. We look at standardization metrics and link them. We look at the model metrics. So what is your model of integrated care to make sure that we're always measuring that? And we look at operationalized or organizational metrics related to that. So we're going to look at all of those, and I'll have examples, and I'll also demonstrate how we link the return on investment and cost savings to those as well. Okay. So we know that there's a lot of organizations. I named some of them earlier. Here's a list of a few more. And for those of you who do specialty care, perhaps it's asthma and immunology as an example here, HIV, et cetera. If you provide any type of specialty care, MAT services, there are specific metrics that are supported for those specialties as well. So just know that. So here, just to kind of demonstrate this piece about how almost every specialty is demonstrating integrated team-based care. Even in asthma and immunology, they have very specific integrated team-based care metrics that they're asking for their specialists to look at. Dental is the same thing. So it's really important to know that these metrics are out there. We don't need to make them up. There's specific measures we can look at from these agencies and entities and bring on and use them. And that helps us too to demonstrate our value in comparison to other agencies like us in our states, in our communities, or across the nation. And how are we doing in comparison? Because a lot of these entities also demonstrate that for us too, which is a great value. So we'll be going over those next month. And we'll talk about how those metrics can be tied to our performas on all of our job descriptions and really be inclusive for our integrated care providers. And then we'll be demonstrating return on investment metrics. What does that look like? What are those calculations involved? Okay, how do we do them? And then what is actually being done with that across the United States for integrated care? What does it really look like? And so we're going to be going over very specific examples and demonstrating that for you. So now I'm going to take a pause. We've had a lot of time, a lot of things we've gone over kind of broadly together today. And I want to take the time to really address any questions you might have. I notice we don't have a lot of questions in the chat box. So this is the time if you'd like to go ahead and unmute or place your question in the chat box.
We have a question, Dr. Manson, in the chat box. The question is, what are a couple of best practice states and or provider systems that Arkansas can learn from?
Oh, that's great. So best practice states, that I'll do that one first. So actually, really that's kind of like one of these things. It really depends. You want to look at states that are comparable or similar related to your community needs. So I've seen a lot of different states and organizations that will look at other states that aren't similar in that, and then they have a little bit of a difficult time. So California has really pushed out integrated care, and they have a lot of support and structure for that, as well as their telehealth delivery related. So that's a great place to look at resources. Oregon's another one. Oregon has actually developed a lot of their actual state Medicaid to require integrated care, and they've actually developed social determinants of health as part of their reimbursement structure through Medicaid. And so that's another great entity, and they have a lot of great resources. Arizona is one that's on kind of the beginning tip of that. They do have the value-based contracts through Medicaid for integrated care sites. They actually have developed an integrated care licensing that's different than just general primary care or general mental health organizations. that all have specific standards involved as well. So they're really helping to operationalize this. So I would say those are a few good states to consider. Idaho is really building the structure and pieces there. So that's a really great network and system to consider because they're really pushing out a lot of the development right now. So those are some that I would say. A few more that are kind of coming along. New York has done a lot of efforts, but they're still coming along because of the diversity of their state. They are predominantly rural, but the areas that are not have the strongest voice. So a lot of kind of the pieces and structure get lost there, but they've been pushing out for many more years as well. And then you've got Texas, which is a large state and been really pushing out, but because of legislative fluctuations and who's been really in charge at that time each year has actually changed the integrated care structure. So in some years they've been awesome and actually pushing out lots of organization structure and support. And other years they've literally shut down integrated care in the state, just even recently. So it kind of goes back and forth. But I would look at, when I start, I'd look at recommending from California, Oregon, we've got Arizona, Idaho, and then you're going to do New York and Texas possibly. Those are the ones that I would say might be good in that order. Okay. Next, I would say those organizations to look at might be good examples. You know, the predominant one usually that people will look at is Cherokee, because Cherokee has a number of great programs where they invite sites on specifically. They have kind of an onboarding section. I know they halted that for a little bit during COVID. I don't know if that's been brought up again. You can look at Prinda is the head there. And so you can see if Cherokee is still doing that. I can always reach out and see if sites are interested in that. But honestly, there are sites all across the United States. What I'd say is first consider, what site are you? What are you really looking for? Are you looking for a primary care site? Are you looking for a larger healthcare system? Are you looking at a demonstration project of a smaller rural primary care site that it's really one or two providers and you're bringing on mental health? Or perhaps you are a primary care site that is a nurse-driven primary care site. Those, I would look at demonstration projects. There are actually demonstration projects in Colorado that have been amazing, looking at smaller rural sites, school-based sites, et cetera, and what they've been doing. Texas has some great school-based sites as well. So I'd really look at the intricacy of who you are and who the communities you serve. And then if people want and they have a specific kind of outlines, even like bullet points, this is my site, I'm rural, I'm a smaller FQHC, or I'm a smaller primary care site or mental health site doing reverse integration, and I really want to bring on this for my population. If you want to send those to me, I have contacts obviously across the United States and into Canada, and I can definitely go, oh, you know what, I think this is a really good site for you. That would be a better way to link it up, because you really want to see a site that's like yours. That's imperative, because we can all look at larger ACOs that are huge and see things that are functioning, like Cherokee is very large. We can look at larger sites and see them and go, wow, that's amazing. But it might be harder for you to replicate that at your organization if you're not similar in structure and similar in being able to hire as well, right? So again, just consider that. Hopefully I answered that question for you. What about others? Or if anybody wants to share any of the challenges you've had with billing or concerns you have about the future of integrated care financing.
Lesley, I know that there are many practices in our state. CPC has been a huge initiative over the last really maybe 9 years, because we had Classic and then CPC Plus. So a lot of practices were able to integrate behavioral health as part of that. And now we're trying to readjust. Primary Care First is coming on board. And so there's an adjustment to that, and practices trying to relook at how they're doing integrated care and billing and how to find that way. So I don't know if you have any other comments about that type of transition. In some ways, it feels like many of us are reeling a little bit to adjust to that. And we have a lot of folks from our payers on this call too that are have helped contribute to advancing integrated care in our state through CPC and other initiatives.
Yeah, really, that's the adjustment that a lot of healthcare entities are experiencing right now, with it moving away and going to our primary care first model, which is really looking at population health, and it's a little bit different of obviously of a model than really this core structure of behavioral health provider integrated care model. Although you can leverage it in that way. So I really want folks to be sitting down. I'd love to see payers and sites sitting down and having open conversations about looking at value-based purchasing in different ways and developing contracts. Maybe they're not going to be here now, but maybe over the next 5 years, and really considering what those should look like. If you're a site and you've been supported by CPC Plus to actually bring on your integrated care providers, I know for a lot of entities, they were paying salaries. So I want to look at and take a step back. And I would say the best thing you can do right now is look at what you've done. Look at what the data you have. Pull the data of the billing data for these providers, the frequency of them seeing these patient populations, and what is the money you actually brought in. Do a quick pro forma from that to see where are you structurally, because it's very easy to think, oh, we can't survive after we have this money, but you may already be surviving with what you're actually receiving of the reimbursement. So I'd look at that first, and just so that you can kind of have a place to know where your baseline is. And then I would start looking at what are the programs I really want to put in place right now? What is helpful for my community? And maybe you do want to kind of leverage some of your other team members or bring on another team member that might be at a different type of operationalized cost, but that will bring on a lot of value, like care management. Perhaps you want to leverage your behavioral health providers into care management, but sometimes that isn't fruitful because behavioral health providers can bill independently more often than not. And care managers are it's that integrated billing. So you're billing through the primary care physician. And so you really want to leverage other types of team members to be able to do that. And that might be something you might want to consider right now. I know that we're almost at time. I also saw, Megan, you commented about the IIBHN. For IIBHN, I believe it was like a 6-hour value-based purchasing workshop for clinics and sites. It might be something where if IIBHN says I can share the slides, I'm more than happy to share them with your network as well. We just need to check in with them. And that might be helpful for people to go through to develop what they want to look at as far as their value-based contracting and having those discussions. So if that's helpful. But truly what we want to know right now is, where are we structurally and financially related to our integrated care program? We want to know, what are we doing right here, right now? And then from that, we can make those intricate decisions of where we're going to go next, because we may need to change those programs because we don't have that CPC Plus. We may need to make adjustments. We may need to move our behavioral health providers to seeing more of our community members and do more of a push than we were previously. Or perhaps we're going to go into, care management models. So, but we need to know that base first. I hate to make decisions when we don't have the data. Okay. And so that's really important. So thank you, everybody. I know I'm seeing with the closing kind of pieces. I will post some resources, so I'll send them to AHB and Kim, I should say. I'll just send it directly to her, so then she can send it out to everybody. I'll send the slides and a PDF for everybody, as well as a list of the resources for the performance if people are interested in that. I can send some of the examples, if folks want as well. And of course, all the references. Okay. And if anybody has other questions, please, feel free to send them to Kim or to me directly. I'm more than happy to take them. People call me all the time with specific questions, especially if they don't get reimbursed. What am I doing wrong? So people can always do that. And then next time, we're going to be talking about our metrics and measures we'll use for integrated care, what's most common in the United States. And then we're also going to be showing the return on investment metrics and measurements. So come prepared with any questions related to that as well. And if you have metrics, come prepared with those so you can share them with others. So thank you, everybody.
Thank you so much, Dr. Manson. It is 9 o'clock, so we will be ending on time. I just wanted to let you all know we will have a follow-up next month, our February meeting. We will be hosting Dr. Manson. She'll be back for the second part of this series, and we really appreciate you. We will get the resources out to you. And if you have questions between now and February, please send them my way, and we will see you again. Thank you, Dr. Manson. Have a wonderful month.